So the surgical replacement of the mitral or the aortic valve during the ARF results in rapid control of the CCF and decrease in the heart size despite investigational evidence for ongoing ARF. So ARF இருக்கும்போது, if you're going to do a surgical valve replacement, it's going to control the congestive heart failure. It's going to reduce the size of the heart as well. Surgical findings thus indicate that it is the acute hemodynamic overload secondary to valvular regurgitation which is responsible for CCF and the morbidity mortality of acute rheumatic fever. Other important conditions associated with streptococcal infection are post-streptococcal reactive arthritis and PANDAS. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with streptococci. PANDAS. P is pediatric, A is autoimmune, N is neuropsychiatric, D is disorder, A is associated with, and S is streptococci. So, as a quick recap, rheumatic fever chorea is aggravated during pregnancy. Earliest valvular lesion in a case of acute rheumatic fever is MR. To a statement about rheumatic fever in children is just the polyarthritis, and most common valve involved is mitral valve. Problem is mitral regurg. True about erythema marginatum is it's usually associated with carditis. About the subcutaneous nodule, it is non-tender, it's present on the extensor aspects. And another thing about the subcutaneous nodule is it is small, not very big, pea-sized. Fever is a minor criteria for diagnosis, and then diagnostic feature of either is Ashkoff nodule. McCallum patch is a diagnostic feature of rheumatic endocarditis. High ESR is not included in major criteria. It's under the minor criteria. Not a major Jones criteria is polyarthralgia. Okay. Circumstances have changed though. About chorea, medications to control the abnormal movements do not alter the duration or outcome of chorea. Milder cases can usually be managed by providing a calm environment. In patients with severe chorea, carbamazepine, sodium valproate, either one, is preferred over haloperidol. A response may not be seen up to 2 weeks. Medication should be continued for the 2 weeks after the symptoms subside. Okay, there is a recent evidence that corticosteroids are effective and lead to more rapid symptom reduction in chorea. They should be considered in refractory or severe cases only. Prednisolone or prednisone may be commenced at 0.5 mg per kg daily with weaning as early as possible. Preferably after 1 week if the symptoms are reduced, although slower weaning or temporary dose escalation may be necessary if the symptoms worsen. Small studies have suggested that IVIG may lead to more rapid resolution of the chorea but have no benefit in short or long term without chorea. In the absence of better data, IVIG is not recommended except in severe refractory chorea. Okay, with that, we are gonna end. Thanks.